PPA in intensive care service (ICU) is frequent in conventional clinical practice in order to prevent stress ulcer bleeding. Such acute pathology can destroy the mechanism of protection against gastrointestinal bleeding, increasing the mortality. In the context, the evidence about the risks and benefits about PPA is limited.
Is Elizabeth Cruz. I'm going to talk about pantoprazole in patients at risk for gastrointestinal bleeding in the ICU. Pantoprazole is a proton pump inhibitor that reduces the amount of acid produced in the stomach. Pantoprazole is used for the treatment of erosive esophagitis, the damage to the esophagus due to stomach acid, and other conditions that produce excessive stomach acid such as Zollinger-Ellison syndrome. Pantoprazole in patients at risk for gastrointestinal bleeding in the ICU, the prophylaxis for gastrointestinal stress ulceration is frequently given to patients in the intensive care unit, that's the ICU, but its risks and benefits are unclear. Okay, continue with the topic. In this European multicenter parallel group blind trial, we randomly assigned adults who had been admitted in the ICU for an acute condition and unplanned admission, and who were at risk for gastrointestinal bleeding to receive 40 milligrams of intravenous pantoprazole or placebo during the ICU stay. The primary outcome was death by 90 days after randomization. The conclusion: in 90 days, 510 patients had died, 31.1% in the pantoprazole group and 499, 30.4% in the placebo group. During this stay in the ICU, at least one clinically important event occurred in 21.9% of patients assigned to pantoprazole and 22.6% of patients assigned to placebo risk. The pros and cons. In the pantoprazole group, 2.5% of patients had clinically important gastrointestinal bleeding as compared with 4.2% in the placebo group. The number of patients with infections or serious adverse reactions and the percentage of days alive without life support within 90 days were similar in the two groups. Financial, the funding request and the projections. The funding request, we will need 1,000 over 5 years. The projections are unclear. Thank you so much for your attention.
Application and nursing. Role of nursing. General nursing measures applied to patient care. Ensure proper central or peripatal veins are well permeable by endotracheal intubation is required. Third, central venous medical pressure every 4 or 6 hours or according to the hemodynamic state of the patient. 4. Place the patient at absolute rest. 5. Administer large volumes of liquid, preferably light ringer, according to blood loss. 6. Number 18 or 12. Caliber nasogastric lever. approval will bypass the single gastric lavage with icy white water until the aspiration of clear liquid is achieved. The use of neuroprens may be assessed. 7. Hydromineral balance. 8. Apply NNT. Yamawa use every 8 hours and place leather under the patient and is necessary. Yamawa infusion enema.
Welcome to Little Lectures, making learning and teaching easy for residents and students on the go. Join our residents from the University of Louisville as they share the highest yield internal medicine topics in digestible chunks.
Hello, my name is Jordan Berlin. I am a third-year resident at the University of Louisville Hospital, and I'm going to talk to you today about lower GI bleeds. This is the second part of a two-part series on GI bleeds. So in talking about lower GI bleeds, it's good to characterize the location, so differentiating between an upper and lower GI bleed. Anatomically, we use the ligament of Treitz as our cutoff for lower versus upper GI bleeds. Anything below this is a lower GI bleed. Some of the things that you're going to encounter when you have a lower GI bleed is either metachesia or melena. Melena you usually associate with a upper GI bleed, but if this is a GI bleed from, say, the small intestine rather than the colon, you can oftentimes see melena. Most of these patients, though, you're going to see metachesia as the presenting GI bleed. It's important to get a good history on these patients. Any history of GI bleeds in the past, lower GI bleeds, any history of upper GI bleeds in the past to kind of characterize, tell you the importance or where to start looking. You want to also know if these patients have had any diverticular disease, any history of hemorrhoids, any NSAID use, and any physical exam or kind of problems that they've personally encountered. Say, if they've noticed that they're fatigued or that they noticed paleness recently. The other thing is to note the quantity and how often they're having the GI bleeds. Is this an acute event that they've just noticed today, it's just started, or has this been a chronic issue, and the amount that they're noticing and the quality of the bleed. On physical exam, the things that you're going to want to look for are pallor. You're going to want to look at the vitals to look for tachycardia or hypotension, which would make you a little bit more worried and concerned. And it should be obvious that you should do a digital rectal exam on these patients. And the big thing is that a lot of these patients who have lower GI bleeds oftentimes present asymptomatically. For your laboratory findings, the biggest thing that you're going to want to get is your hemoglobin.
Process and cons. The nursing process as holistic and integral approach which set to consider the individuality of each patient through the realization of individualized care plan according to the needs identified in the effectiveness and applicability of the nursing process and the knowledge that the staff has to detect any complication of this patient.
That's how I put it. So a very practical medical minute. It's about severe upper gastrointestinal bleeding and the use of Protonix IV. Usually we give boluses of Protonix, especially somebody's nausea, vomiting, limited use of blood or whatever. But when they're very sick, they ask us to start a big bolus, like an 80 milligram bolus, and then a drip of Protonix. The problem with that is that IV proton is not compatible with a lot of the ICU meds, like propofol and fentanyl and vasopressors and things like that. So it does complicate if we give it as an infusion. So the question is whether IV infusion of protonics is better or as good as intermittent boluses given 40 milligrams BID. And the good news for y'all is that it's actually slightly better to give it as boluses, not as a continuous infusion. So even though it sounds better, there's no proven benefit to do a continuous infusion. That makes your jobs easier because it's easier to give medicine twice a day than to have to monitor a medicine IV infusion, and that it takes away a line that you can't use for other things. So if they ever ask you to give an infusion, you can tell them you heard that it was just as good to give boluses. Not that we're not going to do it, but
Dr. Anderson, you gotta do that.
That's right. You can say that. You can quote them. That's it.
Jesus applied in Ecuador. Conclusion. Among the main nursing actions after bleeding are periodic checkups, hospital parameters to detect complications, provide educational lectures to the patients and family to educate them about maintaining a good dietary discipline as well as regular lifestyle. Another action will be aimed at observing and recording the colors, consistency, and volume of feces, and vomiting coincident with the reserve leave to that indicates that the dominant sex in relation to the diseases in the male due to different psychosocial factors and consider that at the present time is a frequent cause of medical urgence and mainly in the elderly because the artery sclerosis not exert the contractile action hemostasis when they are injured and usually blend for the stress of eating habits, alcoholism, physical constitution, and nutritional status.